Now, whenever we do a focus echo or a echo, the questions which need to be answered are what would be what is the left ventricular function? What would be the right ventricular function? Is there any evidence of pericardial effusion and cardiac tamponade? Is there any pulmonary embolism present? Possibility of aortic dissection? What is the filling pressure of the heart? How is the patient responding to the fluid? Is there any acute ischemia or any mechanical complication? Or if there is any intracardiac source of infection. This is a study which was published in European Heart Journal in cardiovascular imaging, where they correlated that the use of echocardiography in acute cardiovascular care, the recommendations were given by the European Association of Cardiovascular Imaging and the Acute Cardiovascular Care Association. What they told is, in the evaluation of shock, the patients with undifferentiated shock, multi-organ CCUS, that is critical care ultrasonography, should be done. And the basic CCE, that is the echo, is useful for the following: in the classification of shock, in identification of life-threatening cardiac causes of shock, which guides the intensivist in establishing initial management strategy with volume, inotropes or vasopressors, and also tracking evolution of disease and response to therapy using CCE examination, that is the echo examination. Echo study often yields immediate results, allowing for the initiation of therapy, while a follow-up advanced study brings the advantage of further refining the diagnosis and providing an in-depth hemodynamic assessment. Now, we are all aware about the RUSH exam, that is the rapid ultrasound for shock and hypotension. The components of the RUSH exam are what we have to look at is the heart, the inferior vena cava, IVC, the Morrison's or the fast abdominal views, aorta, and pneumothorax. The mnemonic would be HIMAP, that is heart, inferior vena cava, Morrison's or the fast abdominal views, aorta, and the pneumothorax. The more simple method would be to consider heart as a pump, where you have to rule out tamponade, you have to see the left ventricular ejection fraction and the right ventricular side. The tank, that is the intravascular, you have to see at the IVC, you have to see at the thoracic and abdominal compartment. And the pipes, which are your large arteries and veins, where you are looking at the aorta, femoral, and the popliteal veins. In use of sepsis, why echo is important? Sepsis represents a complex situation where early hemodynamic assessment and support is the key of sepsis. Now, sepsis and septic shock are common causes of cardiovascular failure in critical care because heart is the victim. Heart could be the source of sepsis in, endocarditis or any infection which leads to, getting inflammation in the pericardium or pericarditis. Now, evidence showed that the use of echo in septic shock led to the change in therapy in large number of patients, majority of which concerned volume status and inotropes. Using echo in the emergency department in patients with undifferentiated shock had specificity of 94% for identifying sepsis. The cardiac abnormalities which we found or which is associated with severe sepsis or septic shock would be, left ventricular dilatation, left ventricular contraction impairment. Either it could be global or segmental. There is a LV diastolic dysfunction. There could be right ventricular systolic or diastolic dysfunction. There could be a ventricular outflow obstruction, that is LVOT. Valvular lesions you can find, that is functional, or it could be endocarditis. Coming on to more about sepsis, the document reassessment of volume status and tissue perfusion is important. Either you have to do a repeat focus exam, that is after initial fluid resuscitation, you have to include the vital sign, your cardiopulmonary, the capillary ripple, the pulse and skin finding, or you can use any of these two. Either you use a CVP, you will SCVOT, or you do a bedside cardiovascular ultrasound and dynamic assessment of fluid responsiveness with passive leg raise or fluid chairing. Now, these two, like the echo and the dynamic assessment of fluid response, these are non-invasive techniques. CVP and SCVO2 is an invasive technique. So definitely the reliance or with these two can be done. If the patient is complaining of chest pain and there is hemodynamic instability and you have to do an echo, so what you are looking at is, and what you have to rule out is the acute aortic dissection, your pulmonary embolism if there's with thrombus, and your pericarditis with tamponade. So whenever we do an echo scan, we do in three views, like parasternal long axis view, which is called as PLAX, the short axis view, and then the apical view. Now, if you see this whole thing, this is aortic dissection. In pulmonary embolism, you have to look at the right ventricle and you have to find if any thrombus is there or not. When you are looking at the apex or the apical view, you have to see the pericardium and is there any evidence of pericarditis or the fluid collection which is leading to the tamponade. Now, the recommendations for echocardiography in patients with acute dyspnea, you have to see the LV size and function in patients with suspected clinical diagnosis of heart failure. You have to do the assessment of diastolic function, that is, you have to look at the AE ratio, the LA volume, then the RVSP. Lung ultrasound is used to differentiate cardiac edema from primary lung disease, to see the pleural effusion, diagnosis, and aspiration, and to rule out pneumothorax. Respiratory failure, the critical care ultrasonography can differentiate ARDS, pulmonary edema, and other causes in the early course of acute hypoxemic respiratory failure. The use of echo, especially in the cardiac, and then the thoracic, that is the lung ultrasound in acute heart failure, resulted in early diagnosis of the underlying etiology. So a meta-analysis was done of 7 prospective cohort studies, which reported that the bedside echocardiography had a sensitivity and specificity of 94% and 92% respectively. And in a prospective study of 136 patients with acute respiratory failure, adding echo to thoracic ultrasonography improved the diagnostic accuracy for cardiogenic pulmonary edema, PE, pneumonia, when compared with the thoracic ultrasound alone. Echo can also be used during cardiopulmonary resuscitation. The bedside echo has been used during pulse check for the diagnosing of any pericardial tamponade, if there's any profound hypovolemia, if there is thrombus in transit, or acute pulmonary. If there is absent cardiac contractility following a reasonable period of CPR, that you have been doing CPR for, let's say, 30-40 minutes, and there is no cardiac contractility on the echo, so it indicates there is a limited probability for return of spontaneous circulation. So you can stop your CPR after doing this assessment. Vascular ultrasonography. So in ICU, a lot of patients, or mostly all the patients, needs central line, and they need dialysis catheter, they need femoral line. So central and peripheral vein catheter placement with the use of ultrasound or with the use of echo, it resulted in reduced complication. So arterial access for catheter placement, ECMO cannulation, throughout any abdominal aortic syndrome, the echo is very useful. Also, the volume status assessment. So if a patient is hypovolemic, or you have to check what is the volume status for this patient, you have to look at the right and the left ventricular side filling pressures. You have to see at the IVC collapsibility. So with respiration, is the IVC collapsible or not? And how much is the dispensability index? How much is your aortic blood velocity variation? And how is the systolic pressure variations? Hemodynamic assessment, how would you do is, you see the left ventricle and right ventricle size and function. You see the diastolic function, the cardiac output, the cardiac index, and the CPU. Stroke volume, LVOT diameter. So cardiac output is, stroke volume into heart rate. The dynamic, if there is any dynamic LVOT, that is left ventricular outlet obstruction, or is there any temporal physiology? So all of these you can, see with the echo. Coming on to ECMO, this is the, this has been the latest trend in the ICU, like any patient requiring whose heart and the lung both are not working, so they require ECMO. So echo is very essential in pre-ECMO evaluation for the condition of heart. So during cannulation, echo is used for proper positioning of the camera. They check the biventricular size and function, the biatrial size and volume, follow up of any pre-existing pathology, the volume status, the presence of thrombus, pericardial effusion, valvular regurgitation. Now, assessment for weaning. So in ECMO, we have this veno-venous, that is VV ECMO, or VA, veno-arterial ECMO. So during assessment for weaning, in VV, what you are looking at is the LVF, the TR, that is the tricuspid regurgitation, and the RVSP, the RV size and function, and if there is any paradoxical septal movement. In VA ECMO, definitely again, LVF, TR, and RVSP, LVOT, VPI, the S wave at the lateral and RV size and function. Weaning from mechanical ventilation by use or with the use of 2D echo, the plan can be modified. So if you do a cardiac ultrasound, that is the 2D echo, and you found that everything is okay, you can proceed for the weaning. But if you're finding if there is, any RV dysfunction, that is, there is increased right ventricular, left ventricular area, there is septal dyskinesia. So in that situation, you have to reduce the positive pressure and you have to reduce the P. You have to check the positive pressures again. You have to aim for the normovolemia, consider pulmonary vasodilators, and then you can start with the process of weaning. If you get elevated systolic or diastolic dysfunction, that is your ejection fraction is less than 35%. So in that situation, you have to optimize definitely the medical treatment. Consider using diuretics, inotropic vasodilators, start pressure support, and check for the EF and stroke volume. And if the parameters are unstable, you optimize your treatment again. If the parameters are stable, you can go ahead with your weaning. Definitely, when we talk about doing echo in the ICU setting or doing echo in the emergency setting, the competency plays a very important role. So the competency in basic critical care echocardiography is now regarded as a mandatory part of training, with clear guidelines are available. The majority of pathologies found in the shocked patient and the patient having shock state are readily identified using basic level 2D and the M-mode echocardiography. If you see at the competency level, so anyone who has acquired standard TT view, that is the transthoracic view, in ALS compliant manner, he or she can recognize major causes of arrest or shock, recognize when referral for second opinion is indicated. So this is the training which is required for doing an emergency echo in the emergency setting. Now, the level 1 competent person should be able to acquire all standard views, that is TT and TE, thoracic and transesophageal, should be able to recognize abnormal versus normal, should be able to diagnose common abnormalities, recognize when referral is indicated, and understand echo versus other techniques. The level 2 person should accept referral from level 1. That is, your level 2 and level 3 would be, you will have to call the cardiologist and the echocardiographers, where they can perform their level 2 and level 3 specialist echo examination, echo for any invasive procedure, and majority of post in echo and echo research. So to summarize this, the 2D echo is very useful in the evaluation of patients with undifferentiated shock or acute respiratory failure as well. Echo offers a wide range of hemodynamic parameters to help the ICU intensivist in adjusting therapy in patients with cardiopulmonary compromise. to the echo in critical care patient can be challenging because of the equipment, mechanical ventilation, tubes, and drains. Now, we need to have this integrated approach for the proper management of the patient. And formal training is important for safe application of focused CC in clinical practice. So there's a saying by William Osler: the good physician treats the disease, but the great physician or the great intensivist treats the patient who has the disease. So this was my take home point, that you need to have the integrated approach. You need to have the echo established into your diagnosing and treatment protocol, because when you do bedside echo, you can definitely look at the heart and the probable things happening to it. You have to see the fluid assessment. You have to look at the inferior vena cava for for the distensibility and other factors. So that is all from my side. The whole goal for this webinar was to tell you about that the echo as a bedside tool, examination tool, should be used, and should be used actually in all the ICU patients. So which will enable you to diagnose most of the condition at bedside, and the proper treatment or the change in treatment can be initiated on initially or at early stage. Thank you from my side.